one of the pleasures of doing this work has been the collaboration with colleagues and friends around the world, including in Great Britain, so it's really fun to be here. Some places I speak, I've got the most kind of least tried, most thought out things to say, like the Royal College of Psychiatrists or the American Psychological Association. But here I've got I'm on the other end of the spectrum. I've got the dry, kind of boring data. But as Alan and Rick have both said, we seem to need that. And it seems to be my role over the last 13 years to be engaged in trying to develop and communicate some of this prospective controlled data about this work. So I'm going to go kind of fast. I want to give you an update on the research that we've done and the research that we're doing now. I do this, my name's up there, but I want to emphasize that I do this research with my wife, Annie, who's having a baby shower for our younger daughter this weekend, so she's not here. But, you know, through the vision and incredibly hard work that Rick's been doing for over 25 years, we've been able to make some progress in this over the last 13 years. So I guess I should use this.
If you probably just the arrows actually.
Okay. The right arrow. Oh, maybe it's this on the system. Yes. Okay. So this is what I was planning to do, but I think I'm going to skip the why study MDMA for PTSD. Probably most people in this room would just say, why not? I want to make sure I have time to read a few quotes from some of our participants in that discussion. So if you want to hear more about that in the discussion, I'll be glad to talk about it. But I'm going to move forward to the other points. So let me just skip through these slides. If you read fast. Okay, now you understand why. So here's what we actually did. This was the first study that we completed a few years ago. The one that Rick talked about with people that had PTSD for about 19 years, MDMA-assisted psychotherapy, and people with chronic treatment-resistant PTSD. It was published in the Journal of Psychopharmacology in 2010 online, 2011 in print version. And so our hypothesis was that first, as in phase 2 studies, it's important to show that you can use the drug safely in people with a certain diagnosis. So we wanted to show that we could use it safely and that it would produce improvement in PTSD symptoms according to standard, validated symptom measures 3 to 5 days after each of 2 MDMA sessions and at 2-month follow-up. The protocol was double-blind, placebo-controlled, as is really totally necessary for the FDA. People had to be treatment-resistant. They had to have had both psychopharmacology and psychotherapy and still have significant symptoms. Most people had had years of therapy and many different medicines. And as Rick said, it was mostly women with childhood sexual abuse or rape. We only had one veteran in the first study. So in the first stage, the double-blind part of the study, 60% of people received MDMA on 2 or 3 occasions, 40% received inactive placebo on 2 or 3 occasions, along with exactly the same psychotherapy. So it was the placebo group was really a therapy-only group. Our primary outcome measure was the clinician-administered PTSD scale. That's kind of the gold standard for PTSD research. It's the measure used in the Zoloft and Paxil trials, the only 2 drugs approved by FDA for PTSD. We also did some other measures, the Impact Event Scale, SCL-90, and the Neo Personality Inventory. I'm going to focus just on the CAT results today. And the therapeutic intervention, this was not take-home MDMA. This was just getting it a few times under direct supervision. So people would have be in the office for sessions that lasted at least 8 hours with a male and female therapist present, myself and Annie in this case. And then they'd stay overnight after the session with an attendant on duty. We would meet with them the next day before they went home, talk to them every day on the phone for a week, meet with them 3 more times at approximately weekly intervals for 90 minutes at least, to help them integrate the experience. And then a month later, they'd have their next session. So that's what this refers to. We paid a lot of attention to preparation. We met with them a couple of times ahead of time to prepare them for the session, and then help with meeting with them to help them integrate it. So it was, we thought ahead of time, and our experience bore this out, that the preparation and integration was a very important part of this. And we measured blood pressure and pulse and temperature a lot more often than we needed to. So our approach, I could say a lot about this. As Rick said, we've written a treatment manual now. We kind of developed it during the first study. Now we're kind of validating it with the second study. It's based on the work of a lot of people that went before, including Lou Zeff, who Rick spoke about. Annie and I both trained with Stan Christina Groff and holotropic breath work, and a lot of it came from what we learned from him and her about what they developed based on LSD psychotherapy initially, and many others that did some of the. There were a lot of anecdotal reports before we started. There was no controlled data before that. It's a non-directive approach, kind of aimed at, well, largely non-directive, I would say, aimed at kind of supporting and facilitating whatever's the person's own experience in whatever way it arises. So we don't have an agenda about now you need to talk about the trauma or now you need to do this. We support them for unfolding in whatever way it does. This is where we do the sessions. People are on the futon. It's actually made up of sheets and blankets during the sessions, but they can either sit and lean against the wall with some more pillows, or they can lie down. I sit over on the blue chair, Annie sits in the other chair. She's got the blood pressure machine and the music over on that side. You can see on the futon there's not only a blood pressure cuff, but there are headphones and eye shades. So we encourage people to spend a fair amount of the time focused inward without talking to us, with their eyes closed and with eye shades and headphones if they're comfortable with those. And then that alternates with periods of talking to us. We have no schedule or agenda for that. We just, it varies a lot from person to person and session to session, and we think it's important to have some of both. We think that MDMA magnifies whatever's there. So it's not just that people are blissed out for a few hours and then everything's fine. It can bring up a lot of painful emotions and revisiting a very painful experience. The MDMA doesn't make that easy necessarily, but it seems to make it possible for people to do it in a way that they hadn't been able to before. And also there are people who have some affirming positive experiences. Most people do at some point too. So we think both of those are important. This is what 3 people from the first study said. So this just points out that it wasn't all just getting blissed out. They also said, it was difficult. It wasn't, I don't know why they call it ecstasy, but it was very, very helpful. So, just getting down to the nitty-gritty, here are our results. The vertical axis is the mean CAP score. And the 4 time points were baseline, 3 to 5 days after the first MDMA or placebo session, 3 to 5 days after the second session, and then 2 months after the second session. So you can see that the placebo group started with the CAPs about 80, or just under 80, which is high. And they actually had a significant improvement. It turned out to be statistically significant even. about a 20-point drop in CAPS. So it shows that there is this therapy with spending all day with two people there. It was actually quite helpful to them. But they still had significant PTSD. 50 was the cutoff for study enrollment. So these people still had very significant symptoms, though they were improved. So now I'll show you the MDMA group. They had almost exactly the same baseline scale. Yeah, it's kind of, it didn't take a lot of fancy statistics. One session with MDMA, the response was very dramatic, and the difference between placebo was maintained now all the way up 2 months, about 33-point spread. So over 50-point drop in CAPS at the 2-month point. Just to give you a sense of whether that's significant or not, in the Zoloft trials, the first drug approved by FDA for PTSD, the difference between Zoloft and placebo was a little under 7 points on CAPS. So it's not a trivial difference. So this is really encouraging. So then that was the, you saw that was the stage 1, the double-blind part of the study. Then stage 2 was the open-label crossover, so that people that had gotten therapy only, been randomized to placebo, after doing all that, having all that therapy, and doing the testing at 2 months, then they could go back and have 2 or 3 MDMA sessions open-label, with the same kind of integration sessions as before. And 7 of the 8 placebo participants elected to do that. So here's what happened with them. You can see the baseline was the original baseline for these 7 people. The next point there is the stage 2 baseline, where they were after they had all the therapy without MDMA right before starting the stage 2 session. And then here's what happened. So it seemed to help to add MDMA as far as we could tell. And we didn't measure it 4 days after each session before, just for cost reasons. But you can see they had a very dramatic response once they did it again with MDMA. And just to show you that those points were statistically significant, the difference. And just, that's the first line that you saw with the active MDMA group, but just to show you they got to the same place through different groups. So this was very encouraging. Looking at clinical significance, which is often defined as greater than 30% reduction in CAPS, in stage 1, the therapy only had a 25% clinical response, and the MDMA had 83% clinical response. Then in stage 2, 100% of those people had a significant clinical response. So sometimes we get home, and I get home after a session, we look at each other and we say, I think this could be a good medicine for PTSD. So, as you probably know, there's been a lot of controversy about neuropsychological effects and questions about possible neurotoxicity in recreational users. So we did neuropsychiatric testing in this first study. The main one was a repeatable battery assessment for neuropsychological status, also the PASAT and the Gray Complex Figure Test. These are all well-validated psychological tests that were done by an independent psychologist, a neuropsychologist from the university. And basically, the results were similar in all of them, so I'm just going to show you the R bands. So R band score on the vertical axis, higher is better. So on the left is MDMA, green is before MDMA, gray is after 2 MDMA sessions. On the right is placebo, green is before, gray is after. So absolutely no evidence of neurotoxicity. In fact, a trend toward a slight improvement in both groups. The study obviously has some limitations, which I'm not going to go into. It's still a small study, but the transparency of the blinding is what we're most focused on here, that Rick mentioned. So there are several ways of going after that. One was to do a long-term follow-up study, which we started after the last person finished the original study. We also published that in Journal of Psychopharmacology last year. And basically, we would, 1 year or more after study completion, we repeated the CAPS, the impact of event scale, the NEO, and then we had our own questionnaire to ask people about their experience. And just so you understand the number, in the original study, we randomized 23 people, had 2 dropouts, so 21 people completed the study, but one of those was someone that wasn't treatment resistant that we kind of added on just to have more experience with veterans. So we had 20 people who were treatment resistant, our original intention, that were in the blinded analysis, but then one of the placebo people did not go on to receive MDMA. So we had 19 people that received MDMA that we looked at several years later, and all 19 completed the questionnaire, 16 completed the CAPS. So here's what we found. It ended up being a mean of 45 months after the last MDMA session. The range was 17 to 74 months. So about 3.5 years later, on average, here's what we found. On the left is the original baseline CAPS. In the middle is the study exit CAPS, the 2-month CAPS for those 16 people. And on the right is a 3.5-year CAPS. No different. That group does include 2 people who relapsed to scores above 50. So what the benefits didn't last for everybody, but on average, people's symptoms were just as low, or a little lower actually, afterwards. If you just look at the 16 CAPS completers, that means 88% of people had sustained benefit after 3.5 years. But of course, you could say, well, maybe the people that didn't do the CAPS also relapsed. We don't think that's true based on what they told us on the questionnaires, but the questionnaire is not a validated instrument, so it's fair to say, okay, maybe you should assume that those 3 people that didn't do the CAPS at the long-term follow-up also relapsed, and if you assume that, it's still a 74% sustained benefit. So, that's not proof, but that's some evidence, I think, that's fairly good that this probably wasn't just a placebo effect. But we still have to do more work to work on that placebo question. And as Rick said, a lot of drug studies take a don't ask, don't tell approach to the blinding. We didn't do that. We had to record after each session. Annie and I had to record what we thought they got, and we had to ask them and record that. So we tracked that. And in the first study with inactive placebo, we were always right. And the participants were usually right, although not always certain. So here's what we're doing now in Charleston, along with their now studies starting in Boulder, Colorado, and Vancouver as well. But I'm just going to talk about ours in Charleston. I'm going to speed up. We got permission to do a relapse study with the 2 people that had relapsed and one other person that we identified that relapsed after the long-term follow-up. All 3 have completed that. Only 2 have completed their measures, but you can see their CAPS was about 90, and they had a very, very dramatic drop with one more session measured 2 months later. So it looks like kind of a booster session can be helpful for people who are running distress in their life and relapse. The other thing we're doing is this training study to give therapists their own experience with MDMA in this therapeutic setting. We did get permission to do that. We had to make it a phase 1 trial, so we're measuring some psychological measures, but we were able to limit the enrollment to therapists who have completed our non-drug therapy training and how to follow the manual, and who are working in or getting ready to work in clinical trials. So far, 3 therapists have done that, and they've all reported that it's been very useful for them, both personally and in understanding what's happening. When you're sitting with someone taking MDMA, it really helps if you know that there's probably a lot going on, even if it doesn't look like it. So you don't have to get nervous and start bothering them about trying to find out what's going on. So this is the main study we're doing now that we're talking about, veterans, firefighters, and police officers with 3 different doses of MDMA. It's the therapy is the same as the first study. The design is very similar in terms of the preparation and the follow-up sessions, but they get low, medium, or full dose MDMA in the same setting. And we do outcome measures 1 month after the second session, and then we break the blind. And then if they got full dose, they get 1 more full dose session. If they got low or medium dose, they get 3 full dose sessions. So everybody gets 3 full dose sessions. And then we repeat measures in 2 months and 1 year. So, and also these measures are all done by an independent rater, psychologist, not involved in the treatment part of the study. And this, in the first study, people told us about a lot of benefits that we didn't capture on the CAPS. So we added some more measures to see if we could at least capture a little bit more of what was happening. So we also added the Brecht Depression Inventory, Global Assessment Function, Post-Traumatic Growth Inventory, Pittsburgh Sleep Quality Inventory, States of Consciousness Questionnaire from the group at Hopkins, and the NEO again. So I'll just give you a little quick flavor of what we're seeing so far. These are preliminary, but it shows you what we're noticing so far. Well, I'm going to skip through this. We've enrolled 14 people now, mostly veterans from Iraq, some military sexual trauma, and 2 firefighters. We do have a police officer in screening. We now have had calls for well over 400 veterans from around the country expressing interest in the study, and we haven't had to recruit. Shows how great the need is. So here's the CAPS. The low dose is green, the full dose is blue, and the medium dose is red. So we're getting some good response. Looks like so far the medium dose is better. I don't know that that's going to hold up throughout, but I think it's going to be just as effective as the full dose, perhaps more. The depression inventory, we're getting some good drops in the medium low dose, no drop in the, medium full dose, no drop in the low dose. Also, if I showed you the individual scores, you'd see that no one who had a low, no one's spec went up. So the idea that maybe MDMA causes depression, we're not seeing that at all. We're seeing improvement. The global assessment of function is improving. Post-traumatic growth is quite good in the medium and full dose, not in the low dose. Pittsburgh Sleep Quality Index.
You've got 5 minutes.
Okay, I'm going to read just a couple quotes from veterans in the current study, and then maybe we can have a little discussion. Let's see. Okay, this person said, let's see. Well, this person said, it feels almost like the inner healer or the MDMA is like a maid doing spring cleaning. It's as if you thought you were cleaning before, but when you got the things you didn't really want to deal with, you just stuck them in the attic. If you're going to clean the house, you can't skip the stuff in the attic. I keep getting a message from the medicine, trust me. When I try to think, it doesn't work out. But when I just let the waves of fear and anxiety come up, it feels like the medicine is going in and getting them, bringing them up, and then they dissipate. And I'll close with this one. This was from an Iraq veteran. It's like PTSD changed my brain, and MDMA changed it back. We excluded borderline personality disorder. We had a lot of people who had many traits of borderline and nobody that met the full diagnosis. Yeah.
Did you notice any qualitative differences between your 75 milligrams and 125 milligrams? Like any general sort of? differences?
Oh, the differences between the
Like that
medium
you
and low dose?
and the investigators saw?
Well,
I know you're
for
blind.
some people, with 75 milligrams, they seem to be able to kind of stay on track with the processing in a way that they didn't as much with the 125. Although with the 125, people tended to have maybe more transpersonal kind of experiences that are also very useful. Although we had one person with 30 milligrams who had a very deep experience, including some transpersonal experience, and that was one person that we guessed wrong about the low dose. We thought they had gotten one of the other doses.
Right, thanks.
Yeah.
Are there any similarities with what people experience during holotropic breathwork?
What was the first part?
Are there any similarities with holotropic breathwork?
Yes. Well, we did holotropic breath work for 10 years, groups every month, and I think there's a lot of similarity between what happened with holotropic breath work and MDMA. So, as George Greer said, there's nothing you can do with MDMA that you can't do without MDMA. You just might not get to it in this lifetime. But we've actually, people that have finished the study and wanted to continue this kind of exploration, we referred to friends who still do holotropic breath work, and they found it really useful. So I think there's a lot of value in other methods like that, non-drug methods in shifting consciousness. Yeah.
Would you say that the anecdotal evidence of people being more depressed after MDMA is due to them getting impure MDMA?
Well, I don't know. I think it's partly that. I think it's also set and setting. You know, people, if they don't have a chance to really stay with difficult things that come up and move through them, have support and a setting for that, they're going to be left with a lot of unresolved things that may have started to come up or been sort of held down. So I think that might be it. I don't know the answer for sure, but we actually, in the first study with inactive placebo, we tracked low mood the week afterwards, and more people in the inactive placebo reported low mood than the MDMA group. Doesn't mean that no one had that. We tell people these emotions come in waves, and you may have more anxiety or more low mood following it, but that's part of the process, and you need to hang with it and let us support you in working through that. So I think it's more a matter of that than the MDMA itself, is my guess. Yeah.
Following from that last one, I have a patient who I think developed PTSD and taken a very large dose. I think it's the second setting that person actually. It was on the second setting, the very large dose. And they had a very traumatic experience. They developed PTSD after that.
Right. The set and setting is so important. We've had one person who had PTSD from the war, but also then told us about her. What came up was basically unresolved high-dose LSD session many years before, and that had been affecting her a lot. She was able to move through that with support. But it's not an easy ride for many of these people. They need a lot of support afterwards. We've had some people really struggle integrating it, but they're able to do it if they have proper support.
Okay, we're going to have some stories to close on.
All right. Thank you very much.